Welcome, students. We are still in the subject Basic Principles of Oral Surgery. It is in this lecture we have two parts. The continuation of the first parts that we take in the previous lecture. In part 3 we will discuss surgical incision and the flaps, and in part 4 we will discuss suturing technique. What is an incision? Incision is a surgical cutting of a tissue or an organ using a surgical blade. What is a flap? And in oral surgery specifically, it is called a mucoperiosteal flap. It is a layer of gingiva, oral mucosa, and periosteum, partially reflected from the bone to expose the bone and the structure below it. This is the goal of the mucoperiosteal flap. If I have, like here, a lesion in the apex of the tooth, if I have cyst, if I have an impacted tooth, I must raise a mucoperiosteal flap to expose the bone, and then through the bone I will drill the bone and reach to the lesion or reach. What are the fundamental rules for incisions and the flap? The first rule is that I should use a sharp new blade of a proper size. The size that we usually use in oral surgery is blade number 15 on a scalpel handle number 3. And the incision should be made perpendicular on the epithelium. When I made it perpendicular, I will make an exact cut. So during approximation, I will hasten the healing. While if I do it in an angle, I will have uneven cutting and delay healing of the incision site. The incision must be carried out with a firm, continuous stroke. When I do incision, I do it in one line. I don't do a jagged or multiple strokes. These multiple strokes also will cause delay healing. The flap design and incision should avoid any injury to an anatomic structure. So, if I want to remove an impacted lower eight, I should not do a lingual incision. Why? Because lingual incision will cause severance of the lingual nerve and lingual artery. I must always use a buccal incision. This is one example, and important thing is to avoid any injury. Another rule is that the base of the flap must be broader than the gingival margin. Why? Because I will have a better blood supply in this case. If I do the base smaller than the gingival margin, I will have area without a blood supply. This area don't receive any blood supply because of the incision line. This area of tissue will then no blood supply will lead to necrosis, lead to infection, and delay and exposed bone and delay healing. So always the base should be broader than the gingival margin. Another one is that the vertical releasing incision should be approximately at the buccal. When I do the vertical releasing incision, I do it starting from the buccal vestibule and end at the interdental papillae of the gingiva, not the other way around. Not to start with the gingiva and end in the buccal vestibule. I will start in the buccal vestibule and end it in the interdental. In mucoperiosteal flap, as we said in the beginning, I will raise the mucosa and periosteum together, both reflected together. How will I achieve it? I will achieve this by a blunt dissection using a periosteal elevator, keeping the periosteal elevator at all times in contact with the bone. This will ensure that I reflect the periosteum and the mucosa together. This is an important thing because reflecting the periosteum without any injury through blunt dissection will hasten healing after I do reapposition of the flap and suturing. The flap tissue should be handled carefully and gently. I must not cause any tear or any pressure on the flap tissue so that it will remain viable. Another rule is that the width of the flap must be adequate. If I want to operate on this premolar, I should at least take one tooth from each side. Sometimes I take two teeth from each side. Sometimes I take one tooth from side and two teeth from the other side because the main function of the flap is to gauge a proper access and vision of the structures beneath it. Another thing I should put in my mind that the flap margins must rest on intact healthy bone. The same, if I want to work on this premolar, I should not put the incision right beside the tooth that I want to operate on, because if I remove bone from here, then the incision line will fall directly over the defect. This will cause flap dehiscence and may cause also tearing of the flap. So always put on my mind that I put the incision on an intact bone, which means not right adjacent to the tooth that I want to operate, one tooth or. What are the types of flaps in oral surgery? The flaps in oral surgery are divided according to the shapes into. The first one is the trapezoidal or three-sided flap. Three-sided flaps according to the sides of the incisions. This is one, this is two, this is a three. So this is a three-sided flap. It is formed by a horizontal incision along the gingiva with two oblique vertical incisions extending to the vocal vestibule. The vertical releasing incision must always extend to the papilla and never to the center of the tooth on the labial or buccal side. I should always include the dental papillae. Don't put it on the buccal or labial side because this will cause dehiscence of the wound. And this will ensure the integrity of the gingiva. The uses of this flap is when I have an extensive surgical procedure that will need a good vision and access to the site. Like this, I have a large cyst, so I must do a three-sided flap to properly reach the area. And especially when the triangular flap will not provide adequate access. The advantages of this three-sided flap: it will provide excellent access, allow surgery to be performed on more than one teeth. If I have this tooth, this tooth, this tooth, I can do multiple operations on multiple teeth. It will cause no tension on the tissue, allow easy reapproximation of the flap to its original position, and it will hasten the healing process. The disadvantage of this flap is that a defect in the attached gingiva may occur, mainly a recession. It may occur, which means not always I will have a recession in the gingiva when I do this. Another type is the triangular or two-sided flap. This is one side and this is the other side. This is a triangle. It is formed by a horizontal incision made along the gingival sulcus with one vertical releasing incision. Also, the releasing incision will start in the buccal vestibule and end in the interdental papillae, like this. See the shape? It is a triangle. The uses of this flap: this is performed on the labial or buccal side on both jaw. We used on upper or lower jaw, and indicated in surgical removal of small root tip, a small cyst, or sometimes in episectomy. The advantages of this flap: it ensures an adequate blood supply, satisfactory visualization, a very good stability and reapproximation. It is easily modified if I want to enlarge this, to convert this flap into a three-sided. I only put one releasing incision in here and voila, it is transformed into a trapezoidal or three-sided flap. The disadvantage of this flap is limited access to long roots. Tension is correlated when the flap is held with a retractor. As we see here, I see tension in the tissue, in the flap tissue. And it may cause also defect in the attached gingiva. Another type is the envelope flap or single-sided, because it is created by a single incision along the gingival sulcus, made horizontally along the gingival sulcus of the teeth. And if I have a dentulous patient, I will do the incision along the crest of the alveolar ridge. The uses of this flap: I could use it in any time, in any type of operation, especially if I have any operation related to the coronal part of the teeth, and especially when I need to do an operation in the palatal or lingual side, because vertical releasing incisions are prevented in the palatal or lingual side due to its it have multiple structures that will be cut or lead to injury to multiple structures like the greater palatine nerve, greater palatine artery, if I do any vertical releasing incision. So, envelope flap, it is the flap of choice in case of palatal incision or lingual incision. Like in this case, I want to expose a canine. This is canine, either for removal or for orthodontic treatment. After this exposure, I will put a bracket and retract the canine to return it into its place. Or if the patient doesn't want to do an orthodontic treatment, I will remove the canine altogether. Another type of flap, and this is the final type, is the semilunar flap. This is a flap is the result of a curved incision which begins beneath the vestibule, like we see here. It begins beneath the vestibule in a bow-shaped course with the convex part toward the attached gingiva. The lowest point of the incision must be at least 0.5 centimeters from the gingival margin, so that the blood supply is not compromised for this thin strap of tissue. Each end of the incision must at least extend to one tooth on each side of the area of bone removal. Like I see here, I am operating on this central, so the incision include this lateral and include this central. It's used in episectomies and removal of a small cyst or root tip. The advantages of this flap is that it is a small incision with easy reflection, no recession in the gingiva because it is not moved. I don't reflect it with the flap. And especially if I have a crown or a bridge, I don't want to compromise the gingival seal and the gingival the healthy look of the gingiva around it. So I do a semilunar flap to treat an episectomy for these teeth. This is an example. The disadvantage of this flap, sometimes it could be performed right over the bony lesion due to miscalculation, scarring in the interior area, difficulty in reapproximation and suturing due to absence of a specific reference point. In other flaps, our reference point was the interdental papillae, but here we don't have a clear reference point, limited access and visualizations, and a high tendency to tear. These are the most common types of flaps we use in oral surgery. Now we will enter to the fourth part and the last part of the subject, basic principles of oral surgery, which is the suturing technique. After we open a flap and we do our operation, I must do reapproximation and suturing of the flap. What are the basic functions of the sutures? First, it aids in wound healing. How? By holding the flap in position and approximation the edges of the wound. When I cover the wound, I will cover the bone and then prevent the bone from being necrotic and infected and complication of the healing. It will aid in hemostasis, as we discussed in control of hemorrhage. I could use a figure of 8 or I could use a horizontal mattress suture to aid in hemostasis of the socket if I have a bleeding. Suture help hold the soft tissue over the bone. As I said, it help in wound healing and help in having a healthy bone and covered by soft tissue. Suture aids in maintaining the blood clot in the alveolar socket. If I want to preserve the blood clot sometimes, or if I put like alvogel or gelatin sponge or Sergioseal inside the socket, how will I secure them in the place in the socket? I will do figure of 8 to secure any type of material I put inside the socket to aid the healing. What are the basic principles of sutures? First, I should grasp the needle. This is the needle. It comes curved with a cutting edge and the suture is attached with it. When I grasp the needle with the needle holder, the grasp should be at the 1/3 point from the end or from the suture of the needle. This is the side when I grasp the needle. When I do the incision, when I do the suture, the minimal amount of tissue between the edge of the flap and the point of entry of the needle is approximately or at least 3 millimeter. I don't do it so close like 1 millimeter, it will cause tear, and I don't do it far away so that it will cause tension on the suture. Approximately 3 millimeter, it is the most accepted distance. The needle should enter the surface at right angle, as we see here. Enter the surface at right angle. To make the hole as small as possible. When I enter right angle, I will exit directly below the entry point. When I enter in an oblique manner, this will cause tearing of the flap during tying of the knot. When doing the suturing, the suture must pass through the mobile tissue, which is the flap, and then the stable tissue. And I should do a slight reflection of this stable side before the suture so that I facilitate the entry of the needle. In the consequence of the suture, if I have like this, a two-sided flap or three-sided flap, the first suture is placed across the papillae at the beginning of the vertical incision. This is the horizontal incision, this is the vertical incision, this is the interdental papillae, and this is the number one stitch that I put for this flap. Why? Because it is an easily identifiable mark, and in most important when reapproximation a two-sided flap or three-sided flap, so that the flap will be held in place and I can do the other sutures correctly. And then after this one, I will close the interdental papillae of the horizontal incision and then see the vertical incision. Sometimes it will need one stitch, sometimes it will need two stitches. When I tie the knot, I should place it on the side of the incision, not place it directly on the incision line, because this will cause an additional tension on the incision. And also when I do the knot, I always put it on the facial side, don't put it on the palatal or the lingual side, because the patient's tongues will always play with the knot. When I tie the knot, it should be not tied too tightly, because if I tie it too tightly, I see blanching of the tissue, which means I cut the blood supply to the incision line, and then I will have necrosis and infection and the tissue dead and the suture will fail and the flap will be opened. That is not what I want. I want to do reapproximation, so it should be firm, not tight. Okay, because the main principle of suture is to do approximation of the flap. When I use the non-resorbable sutures, which are the most commonly used, the black silk sutures are the most common type used in the oral surgery, I should leave them from about 5 to 7 days. This is the sufficient period so that the incision will be healed and there will be no need for the suture. When the patient came to me after 7 days, I tell the patient after I do the suture, you will come after a week from now. I will see if the flap healed successfully and I don't have gaps or dehiscence. I will remove the suture. Otherwise, I leave it another week. These are the basic principles of the sutures. Now, what are the most common suturing techniques in oral surgery? The most common one, and we use it all the time in our dental clinic and in our oral surgery clinic, it is the simple interrupted suture. The advantages of this suture: it is strong, placed 4 to 8 millimeters apart, 4 to 8 millimeters apart according to the length of the incision, so that the tension is shared. Each stitch or each suture is independent, and when loosening one, I don't cause loosening of the others. How will I do the simple interrupted suture? As I said, I will enter the mucosa 3 millimeter away from the incision line in a perpendicular fashion. Then I will turn the needle according to its curvature. It will be emerged from the other side from the incision and continue with the curvature of the needle. I will have side with the free end and a side with the end with the needle. Then do the tie. As we said, we do it firmly, not tightly. This is the first incision, the first stitch. I will continue to do this as long as I have the incision line. This is the simple interrupted suture. Enter the needle from one side, take it from the other side directly in front of the entry point. Enter from here, exit from the here, then do the tie. This is the simple interrupted suture. In the vertical mattress suture, in this type, I will have it pass through two levels, through the deep level and through the superficial level. So when I have a deep incision, this vertical mattress suture will help me in closing it effectively. The needle is passed from the far side. As we said, I leave 3 millimeter. In case of vertical mattress suture, I will leave more than 3 millimeter. I will leave 5 to 6 millimeter and then enter the needle. And exit it also about 5 to 6 millimeter from the incision line. And then from the side that the needle exit, I will re-enter it, but this time superficially. The first one was deep, the second one superficially, about 2 to 3 millimeter from the incision line, and take it from the other side. I will do the tightness of the suture and then tie the knot. Why I called it vertical? Because the shape of the stitch is perpendicular on the incision line. What are the advantages of this type of suture? Better adaptation, maximum tissue approximation, because I have the stitch in two levels. To get eversion of the wound slightly, this is called eversion of the wound, which means I have maximum contact of the wound, which is better for the healing. It is run parallel with the blood supply of the edges of the flap, therefore it will not interfere with the healing. The blood supply will come like this to the wound, so these stitches will run parallel to the blood supply. Another type of mattress suture is the horizontal mattress suture. In horizontal mattress suture, I can use it if I have an incision or if I have a socket, an open socket. If I have an incision line, I will enter the needle, like always, 3 millimeter from the edge, and take it out from the other side. Then from the same side, I will move about 3 to 5 millimeters and then re-enter the needle and take it out from the opposite side and then do the knot. If I have a socket or interdental papillae, I will enter it from one side, take it out from the other side, then go to the other dental papillae, interdental papillae, enter it from the same side, and take it out from the other side, and then do the knot. What are the advantages of this type of suture? It prevents the flap from being inverted inside the cavity, because it will cause eversion of the wound, which, as we said, better healing. Maximum contact. Control post-operative hemorrhage from gingiva around the teeth. Why I use it in this case? Why I didn't use interrupted suture? Because I wanted here to control the hemorrhage. Why it will control the hemorrhage? This is the blood supply. The stitches will be perpendicular on the blood supply, so thereby causing vasoconstriction and aid in the hemorrhage around from the socket. It does not cut through the tissue, so if I have a tissue under pressure, I will ensure that these stitches will last and will cause no tearing or cutting to the tissue. What is the disadvantages? Because of their perpendicular side on the blood supply, it would constrict the blood vessels on the incision and will restrict the blood flow to the edges of the flap. Another type is figure of 8 suture. This suture is used over tooth socket to hold a cloth or to hold any substance that we put inside the socket, like I said, like gelatin sponge, like Surgiseal, like a deform gauze if I have a dry socket. How will I do this this suture? I will enter from one side, from the interdental papillae from the one side, and then exit in front of it. Okay, let's say I will enter from the mesiobuccal side, exit from the mesiolingual side. Then I will re-enter from the distobuccal side and exit from the distolingual side. Then, by doing the tie, I will form the other hand of the figure of 8 or the X. This is the first X when I came from point 2 to point 3. From point 4 to point 1, I will have the second arm of the X. And I will have then figure of 8. How it will be? First, I will do a normal stitch, normal simple interrupted, but instead of cutting the suture, I will continue stitching. And then I will do the knot with the last stitch, like we see here. What are the advantages of this this suture, or what is the indication? It is indicated in long edentulous area, like we see here. I have long edentulous area. Instead of doing single simple interrupted again and again, I do one simple interrupted and then continue suturing to the end. It will be more time efficient. So the advantages is rapid technique, distribution of tension uniformly, can more watertight seal closure, and only 2 knots associated. We will have one knot in the beginning of the suture and a second knot at the end of the suture. But the disadvantage, any cut in one point, or if any one of these knots will become loose, or the incision or all the suture will be open. This is the main disadvantage of simple continuous interrupted suture. While in continuous locking blanket, in this type, I will do first, as we said, I will start as start with simple interrupted suture, do a knot, then enter it to the tissue. But before I withdraw the suture, I will enter it through the stitch, like here. When I enter it here, before I do the tightening, I enter the needle or the thread below the stitching, and thereby I will have this blanket formation, blanket suture formation. It is also indicated in long edentulous area. It will provide the advantages: avoid multiple knots, distribution of tension, watertight closure, and prevent excessive tightness. But its main disadvantage that it prevents adjustment of tension over suture line if I have a swelling. If this tissue becomes swelled, I will have tension in areas and no tension in other areas, and may cause tearing of some stitches. All these sutures, God willing, we will do a workshop inside the clinic. I will do a direct applications of these sutures, and then you will do a practice for these sutures, because only studying them theoretically is not sufficient. You can see videos in YouTube, but the workshop and doing them by your hand is the most important thing. So God willing, if they're at the most appropriate moment, I will make a workshop especially for suturing. How will I do the knot? It is called the surgical knot or the instrument tie. First, I will pull the suture so that approximately 1 to 2 centimeters or 3 centimeters are left from the other side. I will use the needle holder. It will be held horizontally by the right side of the patient, and I will hold the suture with the needle end by the left hand. I will wrap the long end around the needle holder in a clockwise direction 2 times. Clockwise direction means I will do the loops away from me. Away from me. Okay? Then I will open the needle holder and grasp the free end or the loose end of the tie and pull it through these loops and do the first tie. This is the first step. The second step is I do another 2 loops, but this time I'll do them anti-clockwise, or I do the loops toward me. The needle holder heel is still closed. I do the loops, then open the needle holder, catch the loose end and pull it through the loop and do the tie. This is the instrument tie. Also, when we do the workshop about the suture, we will learn how to do the surgical knot properly. By the end of this lecture, we finished the subject Basic Principles of Oral Surgery. See you again in a next subject. Thank you.